Okay, good morning, everyone. Great honor to be given this oration. And Professor Peter said that we need to think out of the box. And I think David Barker thought out of the box and told us that diabetes begins before the beginning. And I've been working with him for last 35 years. I'm going to tell you what we have learned. Pregnancy diabetes, most of the outcomes which people study are short term, while the real ones which are feeding into the diabetes epidemic are the long term outcomes of fetal programming. And I think that's what I'm going to stress. I wrote this editorial for Diabetes Care about 15 years ago, listing all the doubts I had about the diabetes in the pregnancy. And the important ones was that is it really a de novo diabetes? Is there a role for other nutrients other than glucose? Is there undernutrition overlaying the gestational diabetes issues? And finally, short versus the long term outcome. And as time goes, you try to reduce the questions to answer them more properly. And I think today we will discuss three questions. What is diabetes in pregnancy? What is gestational about GDM? And what is the Indian scenario? So, what is diabetes in pregnancy? The concept started in 1964 with O'Sullivan and Mahan publication, which was actually related to risk of diabetes in a woman in later life. It had nothing to do with pregnancy. It later on emerged that actually high glucose in pregnancy has some maternal and offspring outcome association, not only in the short term but also in the long term. And the obesity and diabetes, which are really now ruling the world, probably originate at least partly in maternal so called gestational diabetes. There is concept about genetic and epigenetic programming, and I subscribe more to the epigenetic programming because of David Barker's sort of Varadhasta. And for that, the most important window for programming is preconceptional. That's before the baby is conceived, and periconceptional, that's before the embryo implants into. And some of this was actually also predicted before David Barker by Norbert Frankel for diabetic pregnancies. And he actually suggested that there was a teratogenesis, which is not really the abnormality of the physical form, but also of the functional brain and other outcomes in a diabetic pregnancy. So, how do we diagnose GDM? And there is considerable confusion here. That's why I said, do we know really what is diabetes in pregnancy? There's confusion about glucose load, how much we give, 50, 75, 100. Do we do it in one or two stages? Cut points are many. And time of diagnosis is another issue which is coming up. Outcomes are usually based on statistical distribution and rather arbitrary cut points. Many studies have been done, and currently we are following HAPO outcomes, and we will see how they actually define gestational diabetes. Different countries like UK and Australia have again given their own cut points. But there is considerable confusion. It introduces heterogeneity, and therefore it's not always very easy to compare studies across centers and countries. These are the HAPO figures, both for the outcomes around pregnancy as well as in the child between 10 to 15 years of age. And whichever form of outcome you take, and whether you take fasting 1 hour or 2 hour glucose, they are continuous, monotonic, and There is no cut point at all. So after doing a $1 billion study, I think people faced the problem that there was no gestational diabetes. It's all continuous. Then, of course, you have to sit down and make some sense. And that's what was actually then done. Whether done rightly or wrongly is very debatable, but they used big baby related outcomes. There was no threshold. So they had a committee which used statistical arbitration. And it's not said anywhere that actually it's only an observational study and therefore it's heavily confounded for the outcomes by a number of factors. The main ones being age of the mother, body mass index, the number of non-glucose metabolites which are never even studied or reported, certainly not in the clinical practice. And when you have such a model, reverse causality is always a problem. A number of studies have supported these problems. Many trials where they have done the screening by one step or two step approach, whether people have used lower glycemic or higher glycemic criteria cut point, or whether they have done early or late gestational screening obesity, the outcomes have been similar, telling us that actually the way we are fighting about all these factors is still needs to be refined and we need to really understand what's happening. So first question was, do we really know what diabetes in pregnancy is? I have to say I don't know what it is. The second question, is it gestational? Now, common belief in clinics is that gestational diabetes is brought on by pregnancy. It disappears after delivery and then it may reappear later. If we follow the dogma for diabesity, which is diabetes and obesity, the thinking is that it's genetically predisposing or disposed, and then there are lifestyle factors which actually precipitate it. Genetic contribution by advanced GWAS testing for obesity, for example, the last review by Ruth Luce in 2021 could account for only 6% of the variability of BMI. That means large part of it is probably non-genetic. And in genetics, we have been using the Crick and the Watson model for the central dogma. That information is contained in DNA, it's transferred to RNA, then it goes across into cytoplasm and is converted into a phenotype which is protein. A British embryologist in 1940s said there was a major step between the genotype and the phenotype. He actually said there is something called epigenotype, which in a way determines what the phenotype is. Imagine a sperm and ovum getting together, putting all the DNA in the fertilized ovum, but from that one cell, you get brain, liver, kidney, heart, and everything in the fetus. Therefore, there must be something determining how that genetic message is converted. And he called that as epigenetic. Another British embryologist is well known for his famous quotation. He said, it's not birth, marriage, or death, but gastrulation, which is truly the most important time in your life, because it's in the pre implantation embryo that epigenetic reprogramming is over. And I drew this figure many years ago that actually genome and epigenome are a combined susceptibility. Important thing about epigenetics is that it's modifiable. If we have to think out of box for preventing diabetes, as Peter reminded us, that out of box thinking is that we need to start very early. He mentioned about starting before clinic. I am saying we need to do it before you are born. And that actually is a very difficult thinking. There are a number of studies which showed that a woman whom we diagnose with GDM, because we test her in pregnancy, already has high glucose before pregnancy. This is famous Pat Catalano studies on 38 women whom he studied before pregnancy in early late pregnancy. And as you can see here, the the mothers who were diagnosed with GDM in pregnancy had much higher glucose even before pregnancy. It's only that we are calling them GDM because we have tested them in pregnancy and we decided to call them like that. I reviewed the literature on this, and there are a number of reports in literature. Either, like say Pat Catalano studies, which were systematically done, opportunistic findings like in say Kaiser Permanente system, where they had women who had come to the system for an examination before they became pregnant. Number of cohorts where actually serial data was available. All of them showed that the women who were diagnosed with gestational diabetes had higher glucose before pregnancy. Then I would like to tell you that the only study in the world which traces the life course projection of the glucose into pregnancy is done in my department. It's called the Pune Maternal Nutrition Study, which has started with David Barker and Caroline Fall in 1993, and we are now into 30 years of the study. We have serial glucose and a whole lot of measurements in the families, 800 families over 30 years. Glucose tolerance has been done in the children and parents every 6 years, starting with age of 6 years. And many of these children born in the cohort are now mothers themselves. So that we are now saying we have 30 years of data and 3 generations with serial cardiometabolic risk factors. And we have a biobank which has been collected serially. At 18 years of age, the average BMI of these F1 generation was 19 kg. You don't expect high glucose at 19 kg because we are used to thinking of gestational diabetes or diabetes as a disease of obesity. At BMI of 19, 30% of these young individuals had pre-diabetes, 40% of boys and 20% of girls. And this high glucose prevalence at this age was not surprising to us like Indian physicians who have seen this for last many decades. Girls went on to become pregnant, and we now have data on about 200 pregnancies in the daughters born in the study, and they have given birth to their children. What did I find? Girls in pregnancy who had higher glucose at 18 years of age, they had higher glucose at 12 years of age, and they had higher glucose at 6 years of age. So I call them gestational diabetes, but they were tracking with higher glucose right from 6 years of age. And if you look at the plot on the right side, you can see how higher glucose at 6, 12, 18 years increases risk of what we call gestational diabetes. And higher glucose in pregnancy increases risk of diabetes later. This is the most complete life course tracking of glucose in a woman from childhood into pregnancy and post pregnancy. And this is how strong the associations are at each point. So if you are tracking, or if you are studying tracking, this is one of the best data you can have that glucose tracks from very early life. So therefore, how does it affect the long-term outcome? As I said, I am a DOHAD person, Developmental Origins of Health and Disease, Parker's theory, and therefore I look at long-term outcomes. So I searched the literature, and is there any evidence that treating gestational diabetes as we do it today prevents obesity or diabetes in the child? And the resounding answer is no. If we treat gestational diabetes as we are doing today, it doesn't prevent any of the cardiometabolic risk factors in the child, nor does it prevent obesity. Why should this be? And that's where the concept of epigenetic, periconceptional reprogramming is very important. This was published many years ago. It's a very beautiful cartoon to show how DNA methylation tracks in the gametes, in the fertilized ovum, and in the preconceptional embryo up to blastocyst. So the two sort of gametes meet, form a zygote, and all the DNA methylation markers are completely wiped out within 48 to 96 hours and re-established. What actually determines the re-establishment of DNA markers or DNA methylation markers? It's the intrauterine environment. That includes mother's glucose, mother's lipids, mother's micronutrient status, mother's stress, the atmospheric pollutants which might get into there. So a whole lot of exposome, including maternal glucose, determines the epigenetic re-established state of the preconceptional embryo. And what is embedded in this? The susceptibility to future non-communicable disease. So Peter again said, think of the out of the box. It's before the clinic. We have to understand it's before you are born. And therefore, I actually wrote this again 50 years ago. It's no use closing the stable door after the horse has bolted. And we have been doing this very, very efficiently in our clinical practice. What's the Indian scenario? These are the serial national average birth weights in India over last 30 years. And they have stubbornly remained at 2.8 kg. We are talking about diabetes increasing, gestational diabetes increasing, maybe there is some increase in birth weight, but national average 2.8 kg. What's the average birth weight of a baby born in the UK? I compared it in Pune and Southampton, 3.5 kg in Southampton. So we are full 800 grams smaller. And we are very happy to think of the international criteria and thinking about large baby as an outcome for the gestational diabetes. And we are very happily treating our women with glucoses which are mildly elevated. This was a GIFTS consortium. I am part of it. And we compared the gene risk scores for birth weight in Indian subcohorts versus the English babies. The blue dots are babies born in Exeter, in Andrew Hattersley's FSOC study, which actually I helped them set up, and the 7 cohorts in India and Bangladesh. What you see is for each gene risk score, the Indian babies have many 100 grams lower birth weight. In other words, genetically same for the birth weight risk score, but actual phenotype is many 100 grams smaller. In other words, epigenetics and environment are major determinants of our birth weight. And in India now the situation is we are world's capital of low birth weight babies. We are also claiming to be world capital of diabetes, whatever that means. And because diabetes happens at a younger age, we diagnose it in pregnancy and call it GDM. And we are world's capital of GDM also. So we have a massive double burden of undernutrition and overnutrition simultaneously existing in the population, individuals, and along the life course. The majority of pregnancies are unplanned, therefore, there is not much that can be done before in the current scenario. There is double burden of malnutrition, therefore, we have to tackle under as well as overnutrition. National birth weight, as I said, is 2.8 kg. High prevalence of prediabetes in the young. Gestational diabetes, the way we diagnose today, is a big burden. Very importantly, the most common abnormality repeatedly reported in Indians is fasting plasma glucose, not the postprandial. Even the gestational diabetes diagnosis, as I will show you, largely is driven by fasting glucose. Once you call a woman gestational diabetes, the medical thresholds are reduced, cesarean sections happen frequently, cost of pregnancy increases, and a whole lot of iatrogenic factors are involved. Our babies in gestational diabetes pregnancies are about 100 grams heavier. The LGA is still quite less common. Importantly, in GDM, India is one country where we still report small for gestational age. And there are few long-term follow-up studies, except perhaps in my department, and there are no RCTs of GDM treatment. This is a study we are currently doing in the slums in Pune in collaboration with Cornell University from New York. First 700 GTTs, amazingly we found 35% in the Pune slums to have GDM by IID PhD criteria. And where did this come from? 75% of abnormal GTTs were from fasting glucose and only remaining from the 1 and 2 hour. So as a nation, Indian mothers have low BMI in reproductive years. Indian babies are the smallest in the world. Now I can show in my cohort, intergenerationally, there is a rapid catch-up of growth in the daughters within last 30 years. We seem to be coming out of the multi-generational undernutrition which we have faced. Healthy fetal growth and curtailing the nutritional teratogenesis or programming will require improved nutrition. That means glucose, other macronutrients and micronutrients. And you know my clinical trial of B12 and folate in the preconceptional stage to improve the outcomes. And criteria and treatment of GDM are actually based on preventing fetal overnutrition. So fetuses which have been undernourished for centuries, they are trying to grow to what we think would be normal, and by diagnosing mild GDM, especially based on fasting glucose, we are doing everything to prevent that. If we were to believe David Barker's theory of thrifty phenotype, that is undernutrition in utero being a risk factor for future diabetes, I think there is an urgent need to demonstrate that what we are doing is not causing more harm than good. Primum nocere. So what I would say is that I would redraw Norbert Prinkel's figure of gestational diabetes, which is started in the middle of pregnancy, to extend to before pregnancy. Let people tell you about early diabetes or early gestational diabetes, and you will hear Dr. Mohan in the afternoon. I will give him a big smile and show him this figure. I'll refer him to my studies and other studies to say that early, the way they are defining, is not early enough at all. And in fact, again, we will have to make sure that diagnosing it early and curtailing the woman's nutrition and fetal nutrition will not cause harm is the first priority in the clinical practice. So, take home messages will be there is a lot to learn, and I think there are many young people attending this meeting who would like to take up various researches. This is a very fertile field. We need to be sensitive to local situations and not go by the consensus statements and advices, especially of the big international bodies. We need a national database and registry, and RSSDI and Diabetes India are, I think, the agency which can make that happen. We need ethical intervention. We completely forget about other things once the woman is diagnosed as diabetes. We need personalized guidelines. Diagnosing GDM in pregnancy, even if the new model of early is used, is too late. Preconceptional detection and correction of risk factors should be the priority. And this means that doctors will be disappointed, but public health people will be happy. We need to move from clinic to the community. Mark Atkinson drew this figure for type 1 diabetes in journal Diabetes in 2015. A man was trying to find his coin which he had lost under the light, street light. Police asked him, "What are you looking for?" He said, "I have lost a coin." So police said, "Do you know do you remember where you lost the coin?" So he said, "Yeah, down the street." So he asked him, "Why are you looking under the light?" So he said, "Because there is light here." Investigating gestational diabetes in pregnancy is like searching under the light. I have to thank a lot of people, but especially the community participants, the girls whom you can see there holding the concept note, the first who have grown into beautiful young girls, my staff, my wife who has been the administrator to my studies, and our Sneha Society. We have been funded by the Wellcome Trust, the MRC of the UK, BBSRC, European Union, etc., number of international bodies, and all the Indian funding agencies. We are grateful to them. 30 years studies, 90% plus follow-up is possible only if you have good funding and good people who are doing it. Thank you.